Okay, we're moving on to the penultimate presentation in this session, and that is the entitled Association Between Neighborhood Socioeconomic Deprivation and Likelihood of Lower Extremity Arterial Revascularization versus Amputation, presented by Dr. Akinyemi on behalf of colleagues with the senior author Dr. Cockrell Hughes from Howard University in Washington, D.C.
Hi, everyone. Thank you for the opportunity to present findings from our study. My name is Oluwasegun Akinyemi. I'm a senior research fellow at the Howard University College of Medicine, Washington, D.C. We have no disclosures. Critical limb-threatening ischemia has been shown to be associated with significant decrease in quality of life, significant morbidity, and also increased risk of mortality. And timely arterial revascularization has been shown as a cornerstone of treatment to improve rates of limb salvage. Several studies has also highlighted the association between social determinants of health, such as patient's race, patient's insurance type, patient's income, and the choice of management of critical limb-threatening ischemia. In this present study, we introduce the concept of neighborhood socioeconomic deprivation, and that we utilize the Distress Community Index to further explore the association between the social determinant of health and choice of management of critical limb-threatening ischemia. Our main objective was to determine if there is any influence or if there is any association between neighborhood socioeconomic deprivation and the likelihood of having a revascularization as against amputation in a statewide database. To do this, we conducted a retrospective analysis utilizing the Maryland State Inpatient Database from January 2018 to December 2020. And we identified patients who were admitted with critical limb ischemia and subsequently underwent either a major amputation or a revascularization. The Distress Community Index, which we are using here to capture neighborhood socioeconomic deprivation, actually utilizes 7 economic metrics to capture the degree of poverty of a community. And these metrics are the share of the population who lacks a high school diploma, the proportion of individuals living below the federal poverty line in that community, the share of the population who are unemployed, the share of housing units that are vacant, median household income, a change in number of employees, and also the change in business or establishment in the community. These 7 socioeconomic metrics are translated into a numeric score that ranges from 0 to 100. This number is subsequently subdivided into 5 groups that highlight the level of socioeconomic deprivation or poverty of the particular neighborhood, with the prosperous neighborhood identified as the richest neighborhood. And as we move from the prosperous to the comfortable, mid-tier, at risk, and the distressed, we have increased level of neighborhood poverty or socioeconomic deprivation, such that the distressed communities have the highest level of economic deprivation. So our aim in this study is to find out if this socioeconomic deprivation, neighborhood socioeconomic deprivation, will affect the rate of revascularization versus amputation among patients who has critical limb-threatening ischemia. At the inception of the study, there were about 1.7 million hospitalizations in the Maryland State Inpatient Database, while there were about 5,000 critical limb-threatening ischemia cases among these patients. And about 50% of these patients had lower extremity revascularization, while close to 32% had lower extremity amputations, while the remaining 18% had non-operative management. A look at the social demographics between patients who had revascularization against those who had lower extremity amputations. There was no significant difference in the age group. However, 42% of the patients who had revascularization were women, while only 36% were women among patients who had lower extremity amputations. And if a closer look at the race ethnicity distribution also shows that majority of blacks were having lower extremity amputations, while slightly higher number of whites were having revascularization. We went ahead to conduct a multivariate analysis and adjusted for patient age, patient sex, pre-existing comorbidities. We utilized the Charlson Comorbidity Index to capture pre-existing comorbidities and the smoking status of this patient. By and large, we did not find an association between the distress community index and the risk of the odds of having either a revascularization procedure or amputation, lower extremity amputation, signifies that the degree of socioeconomic deprivation does not seem to affect who gets a revascularization against an amputation among patients who has critical limb-threatening ischemia. We went ahead and conducted a sub-analysis where we looked at how the distress community index affects some measured outcomes like revascularization rate, in-hospital mortality, readmission, and hospital length of stay. And by and large, there was no association between the distress community index and this measured outcome. However, looking at race disparity, we try to look at if there are any race disparity between among these measured outcomes. And the reference group were white patients. Looking at revascularization, black patients were less likely to have revascularization. Readmission, they were more likely to have readmission rates, have higher readmission rates. And a focus on the length of hospitalization also shows that black patients were more likely to have extended hospital stay. Some limitations of our study includes the fact that this is a retrospective analysis and therefore cannot establish a causal link between distress community index and revascularization rates. Secondly, the state inpatient database were primarily designed for billing purposes and may not be suitable for detailed medical analysis. However, the large sample size was an advantage for this study where we are able to detect differences if they actually existed. In conclusion, the distress community index was not associated with the likelihood of having revascularization as against amputation in this Maryland State database. How there were also no relationship between the distress community index and our measured outcomes. However, black patient continues to have higher readmission rates and more extended hospital stay. Thank you for your time. I'll be happy to answer your questions.
Really enjoyed your talk. I think this is a really important question. I'm interested in the dates you chose. So you included 2018 to 2020. When you broke down the data, did you find that the COVID 2020 was different than 18 and 19? And what I'm concerned about is it possible that you had so many more amputations and no revascularizations during 2020 that skewed your data, and were you able to look at that?
Thank you for the question. That's a possibility, but the COVID phase did not actually reflect in the study. It was not captured in our data sets. So that's a bit of a limitation for us.
Great presentation, and really the amount of time you spent to bring this data forward to, I think you're to be commended. I kind of noticed something similar back in the late 2007, 2008, when I took over a managed surgical account running in one of the county hospitals in Manhattan, or at least in New York City. What we found was that these patients weren't even getting to vascular surgeons. They were presenting with a gangrenous foot or gangrene of their foot, and the trauma person on call was doing an amputation in the middle of the night because they're going to end up with it anyway, and they said they were just doing amputations. So I guess, and we kind of put a halt to that, and certainly had a lot lower amputation rate. But my question is, how many of these patients are actually getting to see a vascular surgeon before amputation, and how many be having it done by a non-vascular surgeon? Craig Walker came out with data showing that up to 50% of the amputations never get a vascular study beforehand. So is this an access to care, or what's really driving this, do you think?
Thank you for the question. That also shows a limitation of the data set that we're using, because we are not able to capture the people who do these surgeries. So that we are not, because that was not captured in our data set, we are not able to answer those questions. Thank you.
Kat DeLosa, UC Davis. Great presentation. I just wanted you to maybe elaborate a little bit more on your decision to use the DCI as your measure of socioeconomic factors that you're looking for in these patients. I was just curious because it doesn't seem to account for a lot of factors that typically go into that whenever you're looking at patient access to care.
Thank you. We actually had an hypothesis, and the hypothesis was that we believe that the Distress Community Index may actually be a more robust measure of socioeconomic deprivation or poverty because it has more socioeconomic metrics. So we were actually hoping that there would be an association, but at the end of the study, we didn't find an association. So it was a big issue for us. We were wondering, could it be that this metrics is not sensitive enough, or could it be that social determinant of health did not actually influence revascularization versus amputation rates among patients with critical limb-threatening ischemia in Maryland? It's something that is quite interesting for us. We were hoping that it's a more robust measure of socioeconomic deprivation rather than looking at income or patient's insurance type.
Okay, one last comment?
Yeah, that was a really nice study. A question I have is, it'd be interesting to get a comparator, a different state. And are you able to do that? Or
yes.
Because it would be interesting, because Maryland, there's other parts of the country where the amputation rates are much higher than Maryland. And I think it'd be interesting if you compared it to other parts and see if it actually was a factor for the distressed communities.
Yes, thank you so much. We've already procured the Californian data set, Texas data set, and we intend to repeat these studies and see whether we are going to find the same findings that we got right in this particular study.
Thank you very much.
Thank you.